Okay, tell me again about the differences between types of enteral access. So, regarding the route of access, we have nasal or percutaneous, and then we have gastric versus jejunal in regard to where the feed is being delivered, and lastly, we have endoscopy versus interventional radiology regarding where the access was put in.
All right, let's dive into the differences between types of enteral access, focusing on the routes, delivery sites, and placement methods you mentioned. For the route of access, nasal involves tubes like nasogastric or nasojejunal, which go through the nose and are typically for short-term use. Think weeks to a month. Percutaneous routes, like PEGG tubes, go directly through the skin into the stomach or jejunum, suited for long-term nutrition, often months or years. Regarding delivery site, gastric feeding goes into the stomach, ideal for patients who can tolerate stomach digestion, like those with normal gastric function. Jejunal feeding delivers nutrients to the small intestine, often for patients with gastric issues, like gastroparesis or high aspiration risk, but it needs slower, continuous feeds. For placement, endoscopic methods, like PEG tube insertion, use a scope through the mouth to guide placement, common for gastric access. Interventional radiology uses imaging, like X-rays, to place tubes, often for trickier cases or jejunal access, when endoscopy isn't ideal. Each combinasal or percutaneous, gastric or jejunal, endoscopic or radiology depends on the patient's needs, duration, and anatomy. Want me to dig deeper into any of these?
That's all good.
All right, so we covered nasal versus percutaneous routes.
Let's
Gastric
talk a bit about nasogastric tube feeding. So, it uses the gut. It's easy to pass the tube and it's minimally invasive, right?
Yeah, nasogastric tube feeding is straightforward and uses the gut for digestion, which is great for patients with functional stomachs. It's minimally invasive, since you're just passing a tube through the nose, down the esophagus, and into the stomach. No surgery needed. Easy to place, often done at bedside, but is mainly for short-term use, like a few weeks, because it can irritate the nose or throat and isn't comfy long-term. Anything specific about it you want to explore?
Um, I want to ask you about like risk, like maybe if the tube is misplaced, or if we have, or if it's not tolerated.
With nasogastric tube feeding, misplacement is a key risk. If the tube ends up in the lungs instead of the stomach, it can cause serious issues like pneumonia from feeding into the airway. Always confirm placement with X-ray or pH testing before starting feeds. Intolerance is another concern. Patients might get bloating, nausea, or diarrhea if the feed rate's too fast or the formula doesn't suit them. Slowing the feed or switching formulas can help. Other risks include nasal irritation, sinus infections, or the tube getting dislodged. Regular monitoring and proper securing of the tube cut down these problems. Want specifics on managing any of these risks?
Yeah, so how do we confirm correct placement?
To confirm nasogastric tube placement, the gold standard is an X-ray, which clearly shows the tube's position in the stomach. Alternatively, you can aspirate gastric contents and check the pH. Stomach fluid is usually acidic, around 1.5. Auscultation, where you listen for air sounds over the stomach after pushing air through the tube, is less reliable and not recommended alone. Always double check before feeding to avoid risks like lung misplacement. Need more details on any of these methods?
So we want the NG tube remaining in the midline, down to the level of the diaphragm.
You're likely referring to ensuring the nasogastric NG tube is correctly positioned, ideally with the tip in the stomach, below the diaphragm. The tube should pass down the esophagus, staying midline, and end in the stomach, typically 3 centimeters below the diaphragm level, as seen on an X-ray. This avoids coiling in the esophagus or accidental placement in the lungs. Placement is confirmed with an X-ray or pH testing of aspirated fluid, as I mentioned earlier, to ensure it's safely in the stomach before feeding starts. Want me to clarify anything about positioning or confirmation?
That's so good. Okay, what about the advantages of nasojejunal feeding?
Nasojejunal feeding has some solid advantages, especially for certain patients. Since the tube delivers nutrients directly into the jejunum, it bypasses the stomach, which is great for those with gastric issues like gastroparesis, severe reflux, or high aspiration risk. It lowers the chance of aspiration pneumonia compared to nasogastric feeding. It's also minimally invasive, like NG tubes, and can be placed at the bedside or with endoscopic guidance. No surgery needed. Plus, it supports enteral nutrition over parenteral, keeping the gut active and reducing infection risks. It's typically
What is aspiration?
Aspiration is when food, liquid, or stomach contents get into the lungs instead of the stomach, usually during swallowing or feeding. With nasojejunal feeding, it's a lower risk since the feed goes straight to the small intestine, bypassing the stomach and reducing the chance of reflux into the airway. It's a big concern for patients with weak swallowing reflexes or gastric issues, and it can lead to pneumonia if not caught. Anything else you want to know about it or how to prevent it?
Tell me about the risks of nasojejunal feeding.
Nasojejunal feeding has a few risks to watch for. Tube misplacement is a big one. If it's not correctly in the jejunum, you could get feeding into the stomach or lungs, though this is less likely with proper confirmation, like X-ray or endoscopic guidance. Intolerance can happen, causing diarrhea, bloating, or nausea, especially if the feed rate's too fast or the formula's not right. There's also a risk of tube clogging, since jejunal tubes are narrower, so regular flushing is key. Nasal irritation or sinus infections can crop up, and the tube might get dislodged, needing repositioning. Rarely, you might see small bowel perforation during placement, particularly with endoscopic methods. Monitoring and slow feed starts help manage these issues. Want details on handling any specific risks?
Let's talk a bit about PEG and RIG.
All right, let's dive into PEG and RIG. PEG, or percutaneous endoscopic gastrostomy, involves placing a feeding tube directly into the stomach through the skin using an endoscope passed through the mouth. It's great for long-term feeding, minimally invasive, and works well for patients with normal stomach function, needing months or years of support. RIG, or radiologically inserted gastrostomy, also places a tube into the stomach, but uses imaging like X-ray or CT for guidance, often when endoscopy isn't an option, like in cases of esophageal blockage. RIG is precise, avoids sedation, but might need more aftercare to prevent site infections. Both are percutaneous, good for gastric feeding, but PEG is more common due to its simplicity, while RIG is a solid backup for complex cases. Want me to zoom in on risks, benefits, or something else?
I don't understand. Okay. And so percutaneous endoscopic gastrectomy and radiologically inserted gastrectomies differences is
The main difference between PEG and RIG is how the tube gets placed. PEG uses an endoscope passed through the mouth to guide the tube into the stomach, making it simpler and more common for long-term feeding in patients with normal stomach function. RIG relies on X-ray or CT imaging to place the tube through the skin into the stomach, typically used when endoscopy isn't possible, like with esophageal blockages. PEG often needs light sedation, while RIG can sometimes skip it. Both deliver feed to the stomach, but RIG might have a higher risk of site infection and needs careful aftercare. Anything specific about these you want to dig into?
so good. Okay. PEG and RIG. Let's talk about advantages now.
PEG's advantages include its simplicity. It's a quick procedure, often done with light sedation, and great for long-term feeding in patients with a functioning stomach, like those with neurological conditions. It has a low complication rate, and the tube's easy to maintain. RIG shines when endoscopy isn't an option, like with esophageal strictures. It uses precise imaging for placement, can sometimes avoid sedation, and is reliable for long-term gastric feeding. Both keep the gut active, reduce infection risks compared to IV feeding, and support stable nutrition. Want to compare specific benefits or something else?
So in a few words, I'm still kind of confused. So tell me about the risks too. So this is a procedure we do for what?
PEG and RIG are done to provide long-term nutrition directly to the stomach for patients who can't eat enough by mouth, like those with strokes or cancer. Risks for both include
So how do
infection
they
at the
do this?
For PEG, doctors pass an endoscope through the mouth into the stomach, shine a light to guide a small incision in the skin, and pull a feeding tube through into the stomach, securing it in place, all under light sedation. For RIG, they use X-ray or CT imaging to guide a needle through the skin into the stomach, then thread and secure the feeding tube, often without sedation. Both procedures take about 20-30 minutes and are done for long-term feeding when oral intake isn't enough. Want details on any part of the process?
So good. Okay. Let's talk about percutaneous jejunal access now. Advantages and risks.
Percutaneous?
Yeah, sorry.
No worries at all. So, percutaneous jejunal access, like PEG, has some key advantages. It delivers nutrition straight to the jejunum, bypassing the stomach, which is great for patients with gastric issues like gastroparesis or high aspiration risk. It lowers aspiration pneumonia odds and supports long-term feeding for those who can't use their stomach. Risks include tube clogging due to narrower tubes, site infections, or leakage, which needs careful cleaning to prevent. There's also a chance of tube dislodgement, or, rarely, bowel perforation during placement. Slow feeding and regular tube flushing help manage issues. Want more on any of these points?
Let's talk about total parenteral nutrition now.
Total parenteral nutrition, or TPN, delivers all nutrients directly into the bloodstream through a vein, usually when the gut can't be used, like in severe bowel obstruction or short bowel syndrome. It's a lifeline for patients who can't absorb nutrients enterally, fully customizable to meet nutritional needs. Risks include bloodstream infections from the catheter, liver damage from long-term use, and metabolic issues like high blood sugar or electrolyte imbalances. It's also pricey and needs careful monitoring. Anything specific about TPN you want to dive into?
Why don't we talk about central access lines and some problems with TPN?
Central access lines, like Pixie lines or central venous catheters, are used for TPN because they deliver nutrients directly into large veins, allowing high concentration solutions. Problems with TPN include catheter-related bloodstream infections, which can be serious and need strict hygiene to prevent. Thrombosis or blood clots can form around the catheter, risking blockages. Liver dysfunction, like cholestasis, often shows up with long-term TPN, especially in kids or adults on it for months. Metabolic imbalances, such as high blood sugar or electrolyte shifts, also happen and require regular blood tests to catch. Want me to focus on managing any of these issues?
Yes, how do we monitor it?
To monitor TPN and catch issues early, regular blood tests are key. Weekly or more to check glucose, electrolytes, liver function, and kidney markers, adjusting the formula as needed. Daily weight checks and fluid balance monitoring help spot overload or dehydration. Catheter sites are inspected daily for redness or swelling to catch infections fast. Blood cultures are done if fever or chills pop up. Metabolic bone disease can be a long-term concern, so some get periodic bone density scans. Close oversight by a nutrition team keeps complications in check. Want details on any specific monitoring step?
I want to put a pause to this conversation and go towards imaging of the abdominal viscera now. So, let's start with a nice introduction to the topic. I'll leave it up to you how you introduce us to the topic. Maybe perhaps with ultrasound, which is like a good first line test. Explain why it's a good first line test.
All right, let's shift gears and talk about imaging the abdominal viscera, starting with a friendly dive into why ultrasound is such a stellar first-line test. Picture the abdominal viscera, liver, spleen, kidneys, pancreas, and intestines, all nestled in there, doing their vital work. To peek at these organs non-invasively, ultrasound is often the go-to because it's safe, quick, and versatile. It uses sound waves to create real-time images, no radiation involved, making it ideal for kids, pregnant patients, or anyone needing frequent scans. It's also widely available, relatively cheap, and can be done bedside if a patient can't move. Ultrasound shines for spotting issues like gallstones, kidney obstructions, or liver enlargement, and it can guide procedures like biopsies. Plus, it catches fluid collections or masses fast, often giving doctors enough info to decide next steps without jumping to heavier tests like CT. Want me to zoom in on what ultrasound reveals about specific abdominal organs?
Tell me about CT and compare them in this regard.
CT, or computed tomography, uses X-rays to create detailed cross-sectional images of the abdominal viscera, showing organs like the liver, pancreas, kidneys, and intestines with high clarity. It's fantastic for detecting complex issues, think tumors, abscesses, or bowel obstructions, because it provides precise anatomical detail, often enhanced with contrast dye to highlight blood vessels or lesions. Compared to ultrasound, CT is more definitive for diagnosing conditions like appendicitis or pancreatic cancer, as it sees through gas and bone, which can obscure ultrasound images. However, CT involves radiation, making it less ideal for frequent use or in radiation-sensitive groups like kids. It's also pricier, takes longer, and usually requires a trip to the imaging suite, unlike portable ultrasound. Ultrasound wins as a first-line test for its safety, speed, and ability to catch obvious issues like gallstones or kidney stones, but CT steps in when you need deeper detail or ultrasound findings are unclear. Want me to focus on specific uses of either for certain organs?
I want to ask about intervention. Like, tell me about ERCP and PTC and DSA.
All right, let's talk about interventional procedures for the abdominal viscera, focusing on ERCP, PTC, and DSA. ERCP, or endoscopic rectocolongiography, uses an endoscope passed through the mouth to the duodenum to access the bile and pancreatic ducts. It's great for clearing bile duct stones, stenting blockages, or diagnosing ductal issues, like in gallstone complications or pancreatic cancer. Risks include pancreatitis, bleeding, or perforation, but it's precise for biliary issues. PTC, or percutaneous transhepatic cholangiography, involves poking a needle through the skin and liver to reach the bile ducts, guided by imaging like ultrasound or CT. It's used when ERCP can't access the bile ducts, like in high blockages, to place stents or drain bile. Risks are bleeding, infection, or bile leaks, and it's more invasive than ERCP. DSA, or digital subtraction angiography, is an imaging technique using X-rays and contrast dye injected into blood vessels to visualize abdominal vasculature, like for liver tumors or bleeding. It's often paired with interventions like embolization to block abnormal vessels. Risks include contrast reactions or vessel injury, but it's highly detailed for vascular issues. ERCP targets ducts endoscopically, PTC goes through the liver for bile access, and DSA focuses on blood vessels. Want me to dive deeper into any of these or their specific uses?
Well, I do want to understand them a bit more. Perhaps if you give me a sentence for each one, and so I can start to differentiate between them.
ERCP uses an endoscope through the mouth to clear bile duct stones or stent blockages in the bile or pancreatic ducts. PTC involves a needle through the skin and liver to access and drain bile ducts when ERCP isn't possible. DSA injects contrast dye into blood vessels to image and treat abdominal vasculature, like tumors or bleeding. Want me to expand on any of these?
I see. Interesting. Can we talk a bit about the vessels regarding the pancreas and the spleen, please?
All right, let's dive into the vessels around the pancreas and spleen. The pancreas gets its blood from branches of the celiac trunk and superior mesenteric artery, mainly the pancreacoduodenal arteries, which form arcades linking the two. Its veins, like the pancreatic veins, drain into the portal vein or superior mesenteric vein, tying it to the liver's blood flow. The spleen is supplied by the splenic artery, a twisty branch of the celiac trunk, and its venous drainage goes through the splenic vein, which joins the superior mesenteric vein to form the portal vein. Issues like splenic artery aneurysms or thrombosis in the splenic or portal veins can mess with these organs, especially in pancreatitis or portal hypertension. The pancreas's vessels are intricate and overlap with the duodenums, making surgical interventions tricky, while the spleen's large vessels make it prone to bleeding if injured. Want me to focus on a specific vessel or related conditions?
Interesting.
Glad you're finding it interesting.
What about
So-
X-ray? So, with the stomach, the small bowel, the large bowel. So, it seems like you ultrasound in this case it cannot see through air, so we would choose an X-ray as the first line. Can you explain this a bit more?
Actually, ultrasound struggles with air-filled structures like the stomach or bowels because sound waves get scattered by gas, making it tough to see clearly. X-ray, however, isn't the typical first-line choice for imaging the stomach, small bowel, or large bowel either, unless you're looking for specific issues. X-rays are great for spotting air fluid levels, bowel obstructions, or free intraperitoneal air, which shows up as dark areas under the diaphragm in conditions like perforation. For example, an upright or lateral X-ray can catch a small bowel obstruction by showing air fluid levels, but X-rays lack detail for soft tissues or inflammation, and they involve radiation, so they're not always the go-to. Ultrasound, despite its air limitation, is often preferred first for its safety and ability to spot things like bowel wall thickening or fluid, especially in kids or for quick checks. If you need more detail, CT is usually the next step, as it sees through air and gives a clear picture of the bowels. So, X-ray is useful for acute issues like obstructions or perforations, but ultrasound or CT often takes precedence depending on the suspected problem. Want me to clarify when X-ray would be prioritized for these organs?
Yes, I would like that. And perhaps if you could explain to me a bit about the position, the size, the contents, the mucosal / wall pattern of the stomach, the small bowel, and the large bowel.
All right, let's tackle when X-ray is prioritized for imaging the stomach, small bowel, and large bowel, and then cover their position, size, contents, and mucosal wall patterns. For X-ray, it's a go-to for acute scenarios. Think sudden abdominal pain, where you suspect a bowel obstruction. X-ray shows air fluid levels or dilated loops, like in small bowel blockages. It's also key for detecting free intraperitoneal air, a sign of perforation, seen as air under the diaphragm on an upright X-ray, critical for conditions like a perforated ulcer. X-ray is quick, cheap, and available, making it first line in emergencies, especially when you need a fast answer before jumping to CT, which gives more detail but takes longer. It's less ideal for chronic issues or soft tissue details, where ultrasound or CT shines. Now, let's break down the stomach, small bowel, and large bowel. Stomach, position, sits in the left upper abdomen, under the diaphragm, curving from the esophagus at the cardia to the duodenum at the pylorus. Size, roughly 25-30 centimeters long when empty, but it stretches to hold about 1-2 liters of food or fluid. Contents, food, gastric juices, and mucus, often mixed with air, which shows up on imaging. Mucosal wall pattern. The mucosa has Righe folds that expand with fining visible on contrast X-rays or CT. The wall is smooth, about 3-5 millimeters thick, with layers, mucosa, submucosa, muscle, seen best on CT or endoscopy. Small bowel, position, loops through the central abdomen, from the duodenum fixed near the stomach to the jejunum and ileum, ending at the ileocecal valve. Size, around 3-5 meters long, with a diameter of 2.5-3.5 centimeters, narrowing toward the ileum. Contents, chyme, partly digested food, digestive enzymes, and some gas, with fluid predominant. Mucosal wall pattern. The mucosa has villi and plicae circularis, folds, giving a feathery look on contrast X-rays. The wall is thin, about 2-3 millimeters, with a layered structure on CT, prone to thickening and inflammation like Crohn's. Large bowel, position, frames the abdomen, starting at the cecum in the right lower quadrant, ascending colon, transverse colon, descending colon, sigmoid, and rectum. Now, given the size, about 1.5 meters long, wider than the small bowel, with the cecum at 6-9 centimeters diameter, and colon at 4-6 centimeters, narrowing to the rectum. Contents, feces, gas, and mucus, with more air than the small bowel, visible on X-ray. Mucosal wall pattern. The mucosa has haustra, pouches,
That's so good, that's so good. Can you talk to me a bit about fluoroscopy now?
Fluoroscopy is a real-time X-ray imaging technique that shows moving images of the abdominal viscera, like a video, often used to study the stomach, small bowel, or large bowel. It's great for watching how things flow, like contrast dye moving through the gut during a barium swallow or enema, to spot issues like obstructions, strictures, or abnormal motility in conditions such as achalasia or Crohn's disease. For the stomach, it can highlight ulcers or reflux. In the small bowel, it's used in studies like enteroclysis to check for blockages.
Okay,
And for the
remember,
large
please answer with the least amount of words that allow you to get your point across using the words effectively and efficiently. Having said that, answer to me again about fluoroscopy, please.
Fluoroscopy uses real-time X-rays to show gut movement, like contrast flowing in the stomach, small bowel, or large bowel. It catches obstructions, strictures, or motility issues in conditions like reflux or Crohn's. Quick, functional, guides interventions. Want specifics on its use for any organ?
Yeah, sure. Explain it in a couple sentences, and then I want us to go to CT colonography.
Fluoroscopy provides a real-time X-ray video of the stomach, small bowel, or large bowel, tracking contrast to spot blockages or motility issues efficiently. It's ideal for dynamic studies like barium swallows or enemas. Now, CT colonography, or virtual colonoscopy, uses CT scans to create detailed 3D images of the large bowel, detecting polyps, tumors, or diverticula without invasive scopes. It's quick, needs bowel prep, and is great for screening, but misses small lesions and involves radiation. Want more on its benefits or risks?
Yes, please.
CT colonography's benefits include non-invasive screening for colon cancer, detecting polyps or tumors with high accuracy, and requiring only bowel prep, no sedation. Risks are radiation exposure, missing tiny lesions under 5 millimeters, and potential need for follow-up colonoscopy if abnormalities are found. Want to dive into specific uses or comparisons?
Also good. What's MRA?
MRI, or magnetic resonance imaging,
Sorry.
uses...
Sorry, I thought there was such a thing as MRA too, maybe not.
No worries, you might be thinking of MRA, or magnetic resonance angiography, a type of MRA that focuses on blood vessels. Regular MRI creates detailed images of the abdominal viscera, like the liver, pancreas, or bowels, using magnets and radio waves, no radiation. It's great for soft tissue detail, spotting tumors or inflammation. MRA zooms in on vessels, like those around the pancreas or spleen, to check for aneurysms or blockages. Both are non-invasive, but take longer than CT and aren't ideal for emergencies. Want to explore MRA uses for a specific organ or compare it to something else?
No, so good. Let's talk a bit about the celiac branches now. Left gastric, splenic, and common hepatic.
All right, let's jump into the celiac trunk's main branches, the left gastric, splenic, and common hepatic arteries. The left gastric artery supplies the upper stomach and lower esophagus, playing a key role in gastric blood flow. The splenic artery, long and twisty, feeds the spleen, parts of the stomach, and pancreas, prone to aneurysms in some conditions. The common hepatic artery branches into the hepatic artery proper, supplying the liver, and the gastroduodenal artery, feeding the stomach and duodenum. These arteries ensure the upper abdominal organs get oxygen and nutrients, and issues like blockages or bleeds can hit digestion hard. Want me to focus on one branch or related conditions?
It's just a bit random to me, and it's hard for me to remember the reason. Like, it's so arbitrary to me. Like, these are the three. Why not the right gastric? Why not any other blood vessel? Why the splenic? Why, like...
I get it. The celiac trunk's branches can feel arbitrary when you're trying to pin down why these three left gastric, splenic, and common hepatic are the main ones. It's not random, though. It's about anatomy and function. The celiac trunk is the first major branch off the abdominal aorta, designed to supply the four gut organs: stomach, liver, spleen, and parts of the pancreas and duodenum. These three arteries are the primary ones because they directly and efficiently cover those critical areas. The left gastric hits the stomach and lower esophagus, feeding a key digestive hub. The splenic artery, despite its name, doesn't just supply the spleen, it also sends branches to the stomach and pancreas, tying multiple organs together. The common hepatic artery feeds the liver, a metabolic powerhouse, and branches to the stomach and duodenum, ensuring they're not left out. The right gastric? It's smaller, often a branch of the hepatic or gastroduodenum, so it's secondary. It's just not a major player like the big three. Other vessels, like the superior mesenteric, handle the midgut, not the foregut, so they're not part of this crew. Think of the celiac branches as a streamlined team, each with a clear job to keep the upper abdomen running. Want a trick to remember them, or more on how they work together?
I don't want a trick. I want reality, and I want reality explained through systems thinking, so I can understand it with critical thinking. That's what I want.
All right, let's unpack the celiac trunk's branches, left gastric, splenic, and common hepatic through a systems thinking lens, grounding it in reality to clarify why these three and not others, like the right gastric. Systems thinking looks at how parts interact within a whole, so we'll view the celiac trunk as a subsystem of the body's circulatory system, serving the four guts' functional needs. The circulatory system's goal is to deliver blood to organs based on their metabolic pump and distal organism. The celiac trunk has three trunks: the sigmoid, sigmoidoscopy, barium enema, The digestive system consists of the digestive tube, called gastrointestinal GI tract, and its associated digestive organs. The digestive tract is a series of hollow organs joined in a long, twisting tube that extends from the mouth to the anus. The associated organs include the salivary glands, liver, gallbladder, and pancreas. The human digestive tract is about 9 meters long in a living person, but is about 1/3 longer in a cadaver due to the loss of muscle tone after death. The entire digestive tract can be divided into upper and lower digestive tract. The upper digestive tract includes the mouth, esophagus, stage, bile gas, duodenum. The lower digestive tract includes most of the small intestine, jejunum, and ileum, the large intestine, and anus. The major functions of the digestive system are the transfer of nutrients, water, and electrolytes from the food consumed into the body and the elimination of waste products from the body. Gastrointestinal GI, bleeding. Gastrointestinal bleeding refers to any bleeding that occurs within the digestive tract, which can range from mild to severe and can originate from any part of the GI tract, from the mouth to the anus. The bleeding can be acute, sudden and severe, or chronic, persistent or recurrent over time. GI bleeding is classified based on its location. Upper GI bleeding, bleeding occurring in the esophagus, stomach, or duodenum. Common causes include peptic ulcers, gastritis, esophageal varices, and erosions. Lower GI bleeding, bleeding from the jejunum, ileum, colon, or rectum. Common causes include diverticulosis, angiodysplasia, colitis.
Okay. This is enough. This is enough. Okay. Remember, let's keep things concise. Okay, let's talk a bit about refeeding syndrome now. Back to our previous topic.
Refeeding syndrome can hit when restarting nutrition in malnourished patients, causing dangerous shifts in electrolytes, especially low potassium, magnesium, and phosphate. It risks heart issues, seizures, or muscle weakness, so you start feeding slowly, monitor blood work closely, and supplement electrolytes early. Want more on prevention or specific risks?
So what exactly is it? Explain this a bit more. Explain during starvation and pathogenesis too, like during starvation, energy is saved by switching off transmembrane pumps and sodium drifts intracellularly.
Refeeding syndrome is a dangerous metabolic response when nutrition is reintroduced to a starved or severely malnourished person, causing electrolyte shifts that can lead to heart, nerve, or muscle complications. During starvation, the body conserves energy by shutting down energy-intensive processes like transmembrane ion pumps, leading to sodium and fluid accumulation inside cells as insulin levels drop and glucagon rises, prioritizing fat and protein breakdown for fuel. When feeding restarts, a sudden insulin surge drives glucose uptake, reactivating pumps and pulling potassium, magnesium, and phosphate into cells, depleting blood levels fast. This can cause hypophosphatemia, hypokalemia, and hypomagnesemia, risking arrhythmias, seizures, or respiratory failure. Pathogenesis also involves thiamine deficiency, as glucose metabolism spikes without enough coenzyme, worsening neurological issues. Slow feeding, thiamine supplementation, and electrolyte monitoring are critical to prevent it. Want details on specific management steps?
That's so good. Well, let's talk a bit about how to avoid refeeding. So refeeding is basically that we start feeding. So basically refeeding is we start feeding the patient in a different way. And then because of that, what? Because we start, so its normal way of feeding stops.
Refeeding syndrome isn't about stopping normal feeding. It happens when you restart nutrition too quickly in a starved or malnourished patient, triggering metabolic chaos. Rapid feeding spikes insulin, pulling electrolytes like potassium, phosphate, and magnesium into cells, depleting blood levels and risking heart arrhythmias, seizures, or muscle failure. To avoid it, start feeding slowly, 10-20 calories a day, for high-risk patients, increasing gradually over 5-7 days. Supplement thiamine and electrolytes early, monitor blood work daily, and watch for fluid overload. This cautious approach keeps the body's system stable. Want specifics on who's at risk or monitoring protocols?
Tell me again, so what did I say wrong?
You suggested refeeding syndrome happens because normal feeding stops when you start feeding differently, but that's not quite right. Refeeding syndrome occurs when you restart nutrition too fast in a starved or malnourished person, causing an insulin surge that shifts electrolytes like potassium, phosphate, and magnesium into cells, depleting blood levels and risking complications like arrhythmias or seizures. It's about the speed and metabolic response, not stopping normal feeding. Want me to clarify anything further?
I want to ask you about Wernicke syndrome. Wernicke, what is
Wernicke's
this?
encephalopathy. All right, so Wernicke's encephalopathy, sometimes called Wernicke's syndrome, is a neurological condition caused by a severe thiamine, vitamin B1 deficiency, often linked to malnutrition, alcoholism, or prolonged starvation. It messes with the brain, causing symptoms like confusion, unsteady walking, ataxia, and eye movement problems, nystagmus or ophthalmoplegia. In the context of refeeding syndrome, it's a risk because restarting nutrition in malnourished patients can ramp up glucose metabolism, burning through thiamine stores and triggering or worsening Wernicke's. It's treated with high-dose IV thiamine before starting carbs, and quick action can reverse symptoms, though untreated cases can lead to permanent brain damage or Korsakoff syndrome. Want me to dive into prevention, treatment, or its link to refeeding?
Yeah, explain this a bit more. Just a couple sentences, please.
Wernicke's encephalopathy is a brain disorder from thiamine deficiency, common in malnourished or alcoholic patients, causing confusion, ataxia, and eye movement issues. In refeeding syndrome, rapid carb feeding depletes thiamine, worsening or triggering it, so IV thiamine is given first to prevent brain damage. Want more on specific treatments?
I want you to summarize everything and put it together, please, regarding everything we've talked with nutrition support.
All right, let's summarize the key points we've covered on nutrition support, focusing on enteral and parenteral nutrition, their access methods, risks, and related complications like refeeding syndrome and Wernicke's encephalopathy, keeping it concise and tied together. Enteral nutrition delivers nutrients via the gut, preferred when possible, to keep digestion active and reduce infection risks. Nasogastric NG feeding is minimally invasive, using a tube through the nose to the stomach, ideal for short-term use, weeks, but risks misplacement into the lungs, confirmed with X-ray or pH testing, and intolerance like bloating or diarrhea. Nasojejunal feeding bypasses the stomach, lowering aspiration risk for patients with gastric issues, but narrower tubes can clog, and misplacement or nasal irritation are concerns. Percutaneous endoscopic gastrostomy, PEG, places a tube into the stomach via endoscopy, great for long-term feeding, with low complication rates but risks site infection or dislodgement. Radiologically inserted gastroscopy, RIG, uses imaging for stomach access when endoscopy fails, effective but with higher infection risk. Percutaneous jejunal access, PEG, targets the jejunum for patients with gastric dysfunction, reducing aspiration but risking tube clogging or rare bowel perforation. Total parenteral nutrition, TPN, delivers nutrients via central veins, e.g., PIC or central catheters, when the gut can't be used, like in bowel obstruction. It's fully customizable, but carries risks like catheter infections, liver damage, or metabolic imbalances, high glucose, low electrolytes. Monitoring involves daily blood tests for electrolytes, glucose, and liver function, plus catheter site checks to catch infections early. Refeeding syndrome is a major complication when restarting nutrition in malnourished patients where rapid feeding triggers insulin surges, depleting blood potassium, phosphate, and magnesium, risking heart issues or seizures. During starvation, the body conserves energy by slowing pumps, storing sodium intralistrally. Refeeding reverses this too fast. To prevent it, start feeding slowly, 10-20 calories a day, Supplement thiamine and electrolytes and monitor blood work closely. Wernicke's encephalopathy, tied to thiamine deficiency, can worsen during refeeding as glucose metabolism spikes, causing confusion, ataxia, and eye issues. It's prevented by giving IV thiamine before carbs, especially in at-risk patients like those with alcoholism or starvation.
Okay,
In short,
thank you.